Ken Landau. Thanks for watching. Let's talk about Klonopin or clonazepam. This drug was patented in 1960. FDA approved it for use in the United States 1975, went generic 1997, and it still ranks among the top 50 prescription agents in the United States with more than 18 million prescriptions last year. It's an anti-panic medicine, so it treats panic attacks, anti-seizure medicine, treats certain types of seizures. It's used significantly off-label and unfortunately used as a recreational drug. Name is confusing, and that's a problem. The doctor says you're supposed to take some Klonopin or clonazepam, but you get the clonidine instead because it sounds kind of similar, and the druggist makes a mistake. That's an antihypertensive or a clozapine. That happens to be an antipsychotic, or clobazam. That happens to be another benzodiazepine, but it's used at a completely different dosage. The Klonopin has hypnotic activities, sedative activities, it's anti-anxiety effects, anti-convulsive effects, it's a muscle relaxant, and it tends to cause a certain degree of amnesia. Well, panic disorder, having unexpected panic attacks, and then having worry about the panic attacks, being worried that they're going to recur and worried about the consequences of the attacks, and then they change your behavior because let's say you had your first attack while you were sitting in the dentist's office, you won't go back to the dentist. You had it while you were driving in a car, you're not going to get back in a car. Had it in an elevator, you're walking up the steps. Well, it's also used in seizure disorder. It could be used either alone or as an adjunct to other medicines, used in partial epilepsy typically, used for the akinetic seizures or the myoclonic seizures, absent seizures, petit mal epilepsy. But it's not really a great drug, and as a matter of fact, in about 30% of the people, it loses its effectiveness within a period of about 3 months. Now, it could be increased in the dose and may regain its activity, but that's why it's typically used with another medicine, maybe valproate. But as a matter of fact, the Klonopin doesn't seem to be even as effective as Tegretol or phenytoin. Now, it's used off-label in a significant number of instances, so lots and lots of reasons to use the drug off-label, according to some people, but the Food and Drug Administration doesn't agree. So it's used for social phobia and social anxiety disorder, generalized anxiety. It's used for bipolar disorder or mania, or used for grinding your teeth, something we call bruxism, or the chronic restlessness that seems to come on in people who are taking drugs in the family of the atypical antipsychotics like Abilify or Zyprexa or Seroquel, used for the spasticity of ALS, Lou Gehrig's disease, to help with alcohol withdrawal, people who have problems while they're asleep. These are the people who are the sleepwalkers, the sleep talkers. Maybe they get up at night and eat. Or hyperekplexia, a condition typically in children where they have hyper-exaggerated startle, used for people with restless leg or insomnia, used for people who have something known as the REM sleep behavior disorder. In REM sleep, you have these vivid dreams, but you lie perfectly still. Well, in the REM sleep disorder, your muscles aren't controlled, so you flail about. Well, Klonopin can reduce that. It's used for people with burning mouth syndrome or Tourette's and tics, used for withdrawal from short-acting benzodiazepine. Remember, this is a long-acting benzodiazepine, used in people with fibromyalgia or neuropathic pain, and even used in people who have the common faint on a repetitive basis. Panic attacks are very common. It's estimated that 2 to 3% of the population suffers from them, unrecognized in about 50% of the people. And interestingly, the first drug approved in the United States for treatment of panic disorder, panic attacks, was Paxil. That's right, Paxil, the selective serotonin reuptake inhibitor, the antidepressant. That was the first drug. Well, panic attacks are unexpected. They're associated with a discrete period of intense fear or discomfort. The onset and the maximum intensity is within a period of about 10 minutes, and you have to have at least 4 other symptoms associated with it. So it's not just the fear, but you also have a pounding heart, a racing heart. You perspire, you tremble, you have a sensation that you're choking or you can't get your breath. You have some pain or discomfort in your chest. You have nausea or abdominal distress, or you feel dizzy or lightheaded, feel like you might faint, or derealization, where you seem unattached to reality, or depersonalization, where you don't seem to be involved in the activities, or you fear you're losing control or going crazy, or you fear you're dying, or you're having paresthesias, numbness or tingling of your hands and your feet, or you can have some hot sensation, hot flashes. And after at least one attack, for at least 1 month, you have to have persistent concern or worry about having additional attacks and the consequences of those additional attacks, and that leads to maladaptive behavior. You don't have the candy bar, you don't go back to the dentist, you don't ride in the car, you won't get in the elevator. And it can't be secondary to another drug that you're taking, a side effect of a drug, and can't be secondary to a psychiatric disorder like obsessive compulsive disorder or social anxiety disorder. The studies in panic are all relatively small, and they show that if you take Klonopin, you might be free of your panic attacks in somewhere between 2/3 and 3/4 of the people. With placebo, 1/3 to 1/2 of the people might be totally resolved. On the other hand, lack of complete remission occurs anywhere between 20 and 40% of the people on studies, and in the community, up to 2/3 of the people don't get the significant benefit that the clinical studies show. And the relapse rate, if you stop taking the medicine, can be as high in a period of 6 months as 20 to 50%. So the question is, how long do you have to take the medicine? The answer is we just don't know. If we combine the medicine with some cognitive behavioral therapy or other kind of therapies, then maybe it's possible that you can get off of the drugs. Now, studying how much medicine you need to take, what's the most appropriate dose, seems like 1 milligram might be the sweet spot. But if you take the 1 milligram, it's only going to reduce the number of panic attacks that you have per week by about 1. And if you start off having 2 or 3 or 4 or 5 panic attacks, hey, you still are going to have some issues. Well, in a flexible dose, seeing that if even a higher dose might be better, people taking on average of 2 to 2.5 milligrams of the drug, they still only had 1 fewer panic attack per week. Now, there's a tendency in the United States right now to get people off the benzodiazepines. The government has said the benzodiazepines are bad. Yeah. Well, they try to get you on the selective serotonin reuptake inhibitors, the SSRIs or the SNRIs. But number one, the effectiveness of the 2 classes of drugs seems to be about the same. And number 2, it seems that the doctors aren't buying it because we still have a significant number of benzodiazepines that are prescribed. And number 3, now that more and more people are on the SSRIs, and we have a lot of experience with the SSRIs, we know that that's not a very safe category of drugs either. And as a matter of fact, over a period of the past 20 years, most of the studies that involve benefits from treatment of panic have involved the benzodiazepine. So what do? You start off at a dose of about 0.5 milligram, 1/4 milligram, taken twice a day. Some people take their total dose just at nighttime. You slowly can increase that dose up to 1 milligram a day. That's the optimal dose. If you take 2 milligrams, 3 or 4 milligrams, seems to be less effective. Interestingly, less effective if you take a higher dose. And not only is it less effective, but you might have a higher risk of complications. Well, if you have seizures, different story. You need more of the medicine. So you take a dose of 0.5 milligram, probably 3 times a day. So the total starting dose would be 1.5 milligrams, and slowly increase it. And people who have seizure disorder frequently take a dose anywhere between 2 milligrams and 8 milligrams a day, but it could be as high as 20 milligrams. You keep increasing it until you either have toxicity or you control the seizures. Now, there are warnings with the medicine because it can interfere with your cognitive and your motor performance. So it can make driving hazardous or operating heavy machinery hazardous. And especially if you combine it with alcohol or other central nervous system depressants like an opioid, or you take a sleeping pill. And it can increase the thoughts of suicide or the ideas that you might want to commit suicide, especially if you happen to be depressed. And we know that if your mood seems to change, there might be a risk. Actually, the risk seems to double in people who are taking the Klonopin versus people who are taking the placebo. But the risk is relatively small, even though the risk increases by about 3.5-fold in people with seizure disorder and 1.5-fold in people with panic. But even though the 1.5 seems to be less than the incidence with seizures, it starts from a much higher threshold. So people are more likely to commit suicide if they have the therapy with the Klonopin for panic than for the epilepsy. Well, have to realize that there are different kinds of epileptic seizures that an individual may have, and it's possible that Klonopin can precipitate an increase in the incidence of seizures or change from a focal to a grand mal seizure that requires additional medicine or additional higher dose. And we find that if we combine it with the valproate, which it frequently is, that might lead to an increase in the risk of absence states. And it can cause an increase in salivation, so you have much more saliva that you produce. And some people have difficulty handling the saliva. So people have respiratory distress, people have COPD. And it's certainly not recommended for people who have schizophrenia. If you have schizophrenia, then it seems that this drug might precipitate violent behavior. And in 2016, the Food and Drug Administration put out a warning for all benzodiazepines and said, hey, if you combine them with opioids, you might increase your risk of overdose and death. Side effects of the drug are drowsiness or sleepiness or unsteady gait or abnormal eye movements or double vision or having that glassy-eyed appearance or headache or respiratory distress or slurred speech or dizziness. And then there's confusion and motor impairment. People can become depressed or develop amnesia or have hallucinations or psychoses. People lose their appetite. They become anorexic and can become dehydrated. Those, fortunately, aren't terribly common, but they do lose their libido. And paradoxically, some people who take the drug become excitable or irritated or agitated. They become hostile, and they have sleep disturbances. Some of the central nervous system depressant activity can be potentiated if you happen to take the drug with alcohol or narcotics, opioids, or barbiturates like phenobarbital, or the hypnotics, sleeping pills, anti-anxiety medicine, the phenothiazines that are used to treat schizophrenia, or the MAO inhibitors, or the tricyclic antidepressants. You shouldn't take them if you have narrow-angle glaucoma. Studies show that pregnant women who take the drug might put the newborn at risk in the first trimester for certain birth defects. In the third trimester, the drug lingers in the fetus so that somewhere between 3 days and 3 weeks after birth and lasting up until several months, the child might have hyperreflexes or breathing difficulties with apneic spells, or might be irritable or restless, or might suffer from tremors and jitteriness, might have cyanosis, and might have difficulty eating, sucking. So if a person's pregnant and needs to take a similar medicine, probably Valium would be a much safer drug. In the geriatric population, people over age 65, well, there's a problem because the drug lasts a long time in the system. In normal people, well, as you get older, your liver function isn't quite as good, your kidney function isn't quite as good. So we begin at the lower dose. We begin in maybe about half of the dose that we would use in a person who's 30 or 40 or 50 years of age. We try to limit the therapy to several weeks because of the liver and the kidney problems. It's metabolized more slowly. It tends to build up, so it's in the system for a longer period of time, and that increases the risk of motor vehicle accidents and other kind of problems. And then we have the issue of physical and psychological dependence with the medicine. So it's not really good for people who are addiction prone. You can become tolerant or dependent on the drug in 4 weeks, about a third of the people, and that leads to withdrawal symptoms if you happen to try to stop the medicine. Tolerance has to do with chemical changes that occur on the receptors. So it's not really good medicine for long-term use in epilepsy. We have other medicines that are quite good. So if you decide you want to stop the medicine, you have to slowly discontinue this medicine after you've been taking it for a while, because otherwise you're going to have a withdrawal reaction. A withdrawal reaction might be an increase in anxiety, increase in the panic attacks, increase in the seizures. Might have to do with lack of sleep, insomnia, or tremor, or sweating. Might have to do with headache, or nausea, or muscle cramps, fatigue, or confusion, or depression, or even hallucinations and seizures in some people. And unfortunately, you can take too much of the medicine, you can overdose on the medicine, then you become confused, insomnia, and you have difficult time staying awake, your blood pressure can go down, you develop nausea, you have impaired motor function, people can even develop coma. And interestingly, this drug can be cyclical in its effect. So you can go from being fully awake to being almost comatose to being fully awake. Well, there are medicines that are available to reverse the effect of Klonopin, but unfortunately, since it reverses the effect, it may lead to seizures, may lead to status epilepticus. That's kind of bad. Well, recreationally, we know that sedatives and hypnotics are extremely frequently abused. As a matter of fact, benzodiazepines, of which this is a member, are the second most frequent drug implicated in drug shopping. The way the drug works is it binds to the GABA-A receptor in the brain, causes an increase in GABA. Gamma-aminobenzoic acid is an inhibitor of the central nervous system activity. So it suppresses the activity. That's the way it works supposedly in seizure. That's the way it works supposedly in the panic disorder. It works on a lot of other mechanisms. So it works on the chloride channels and the calcium channels. It works on the glutamate decarboxylase activity. Once you take the drug, it's rapidly and completely absorbed, so about 90% gets into the system. The maximum amount is there in 1 to 4 hours. Some people it's delayed to 4 to 8 hours. Most of it's bound to plasma proteins. That means most of the drug in the system is not going to be effective. It's only the free chemical that's effective. Some people see the effects within 1 hour of taking it, but the half-life can be anywhere between 30 and 40 hours. So it lasts a long time once you take one pill. And the clinical effect is only noticed for about 6 to 12 hours in an adult and 6 to 8 hours in a child. Now, the plasma level, if we were to draw to find out how much medicine is in your system, send it over to the laboratory, at the same dose, people can vary tenfold. And as a matter of fact, it's kind of difficult to measure the amount in the system. You have to preserve the specimen in sodium fluoride. You have to store it at low temperature. You have to analyze it very quickly. The drug itself is going to be metabolized. It's going to be metabolized by an enzyme present in the liver known as the 3A4. And that means if you have liver impairment, you have to be careful because you might not be able to metabolize the medicine. And if you have kidney impairment, that's the way the medicine is going to be excreted. So that's another issue. It doesn't tend to interact with a lot of medicines, but other medicines can interact with its metabolism. So if you take dilantin or phenytoin, if you take tegretol, or if you take phenobarbital, all of those are going to induce that 3A4. So they're going to increase the metabolism of Klonopin and decrease its level in your system by about 30%. On the other hand, if you do something to stop the activity of that 3A4, like you drink a glass of grapefruit juice, or you take some clarithromycin, or you take some Flagyl, then the level of the Klonopin in your system is going to go up. Well, how much is all of this going to cost if you decide that this is an appropriate medicine for you and the doctor wants you to take it? You can buy the medicine for cash, a month's supply, at a dose of 1 milligram for less than $45, and with a coupon for less than $20. If you want to buy the brand name, with the coupon, it's going to cost about $190. And they do make an oral disintegrating tablet, a wafer that you put in your mouth. That's going to cost a little bit more, but it may well be effective in those individuals who have difficulty for one reason or other swallowing, for children with epilepsy. So if we talk about Klonopin. It's still very popular. It's popular for panic disorder, for seizure disorder, especially when it's combined with valproate or some other kind of a medicine. And it's frequently used off-label for an enormous array of conditions for which proof of effectiveness really isn't there. Remember, this is a benzodiazepine. It's a controlled substance. It's in the same family as Xanax and alprazolam or Lorazepam or Valium. So if you do decide to take the medicine, do be careful. Thanks for watching. I'm Dr. Ken Landau.